This is a lecture on current treatment modalities for impacted third molars. The outline of this course are the following. Part 1 would be the current concepts in the management. That includes the rationale of surgical removal of impacted third molars, assessment of difficulty in the managing of impacted third molars, and then part 2, technical review on the third molar odontectomy procedure that would pass on the key techniques of its removal as well as complications with its removal. And lastly, part 3 would be other management options for impacted teeth. This includes third molar and other non-third molar impacted teeth. To achieve this objective, evidences from reference texts that includes textbook of oral and maxillofacial surgery as well as the contemporary oral maxillofacial surgery together with other known textbooks on OMS, third molar, and impacted tooth management textbooks are used together with published papers. Both clinical and imagings that has been placed in this lecture are from my collection of actual cases. I have augmented this by published clinical, radiographic, and diagrammatic references to enhance the understanding of the concepts presented in this lecture. My personal insights is also given during the course of this lecture. I would specifically identify such. Part 1, Concepts in Management and Determination of Difficulties. Current concepts in the management of third molars, particularly when it fails to fully erupt into functional occlusion, includes position papers like that from the American Association of Oral and Maxillofacial Surgeons, published in 2016. In this white paper, the general indication for the surgical management of third molars are those associated with disease or at higher risk for the development of a disease. Another general consideration according to the AAOMS position paper is that in the absence of disease or a significant risk of disease, active clinical and radiographic surveillance is highly advised. Since most of the controversy is on the prophylactic removal of impacted tooth, AAOMS has referenced findings and research and came to a positioned premise that in cases of asymptomatic disease-free third molars, there is no available predictable method to tell which third molars will develop a disease or would cause a disease or problem in the future. As such, the decision on which impacted teeth are of higher risk of developing or causing a disease fall upon the individual clinician's experience and expertise. In so doing, it is affirmed by the AAOMS that removal of an asymptomatic disease-free impacted tooth may be indicated when it is currently or likely to be non-functional, or in cases for removable prosthetic considerations, as well as orthodontic treatment considerations, and in cases of a planned orthognathic surgery. Also included, should active surveillance be opted, is that we should inform the patient of two significant probable outcomes, which is very recommended. First is that it is possible that they could live their lives without the disease-free wisdom teeth causing any problems to the patient. However, as another point, should they opt or if it becomes necessary to remove the wisdom tooth at a later age, then there can be an increased difficulty as well as an increased rate of complication associated with its removal as a patient age. Universally accepted factors that may indicate an uncomplicated removal of an impacted tooth includes the following clinical factors: good access for instrumentation, periodontically involved teeth, a virtually intact crown, and a young patient. These clinical factors is bound together with the radiologic factor's simple root configuration as well as well-defined periodontal spaces. On the other hand, this radiologic factor that includes complex bulbous root morphology, dense alveolar bone, and those that may approximate vital structures or are very high or deep into bone, and also those heterotrophic impactions, together with clinical factors such as patient's history of difficult extraction, a grossly carious third molar with the likelihood of crown fracturing during removal, and atrophic edentulous mandible among middle-aged patients may indicate a more complicated removal. The most widely used diagnostic tool that can be used to assess the level of difficulty among impacted tooth is a panoramic radiograph. This example of a case, however, may present additional questions like, would a crown be accessible buccally or lingually? Of course, these questions have significance in terms of how complicated the removal of these impacted premolars would be. This could be answered by localizing the tooth, either or both using topographic techniques as well as tube shift techniques with the SLOB or slub principle. Of course, CVCT can now resolve this issue with precision. However, three-dimensional interpretations have a separate lecture on its own. A specific localization technique I'd like to focus in this lecture is the sketch shift technique, where in a series of X-rays, usually a periapical film, is taken. The first is taken with the recommended tube angulation. Second one would be taken with the tube shifted to a different position, keeping focus on the object of interest. Usually, this is done by moving the tube either towards the mesial of the tooth or distal of the tooth. It, however, works also by moving the tube towards the crown or towards the apex of the tooth. This diagram shows what would happen when the tube is focused apically. That is, when the tube is pointing more towards the floor. The topmost picture is when the inferior alveolar canal is located lingually to the apex of the tooth. The second exposure would show the IAC moving towards the same direction as the tube. That's going towards the floor. On the middle picture, where the inferior alveolar canal is located on the buccal of the apex of the second molar, the second exposure would show the IAC moving opposite the direction of the tube. That is, it went up. On the lower picture, we see no difference in the IAC on the second exposure. Now this happens when it is located along the same plane as the apex of the tooth. Take this actual case as an example. The one on the right is the second exposure. I have shifted the tube towards the mesial of the impacted canine, and then following the slub principle, same lingual, opposite buccal, the red marked supernumerary tooth moved, yellow circle, together with the tube's shift, and thereby now superimposing on the impacted tooth. Same movement, same lingual. Next, look at the other red marked supernumerary tooth. After the shift, the yellow circle, it moved towards the opposite direction, shortening the distance between this supernumerary tooth and the premolar, opposite buccal. Finally, look at how the impacted tooth, marked red, moves in relation to the root of the lateral incisor. There's a yellow circle. Nothing has changed with the relationship of the premolar, canine, and the lateral incisor. Interpretation is that this is along the same line or plane as that of the lateral incisor. So interpreting this series of radiographs, following a mesial shift of the tube in relation to the impacted canine, this supernumerary tooth is lingually located, while this supernumerary tooth is buccally located in relation to the impacted canine, suggesting the object, which is the impacted canine, is between the two supernumerary tooth and directly in between the roots of the lateral incisor. Now, there are a various number of classifications used to describe impacted teeth, from Pellin-Gregory to Winters, Peterson's, and others. They would also be used as basis to determine the level of difficulty in removing this impacted tooth. Several texts have also identified these determinants of difficulty. In this lecture, however, I would only focus on some that I feel are commonly seen, yet oftentimes commonly neglected as well. Starting with the application depth. This is considered by most as a predictive factor to the level of complicatedness in terms of a surgical removal of an impacted tooth. It is also the most common basis that clinicians look at. It is based on the fact that the deeper the impaction is, the more bone reduction will be needed to reach the optimal application of the instruments. In this diagram, various angulations show the difference in the depth needed to reach the application point of the instrument, that which is the point where forces can be effectively applied to displace the tooth out. The next indicator that clinicians commonly see but may take for granted is the roots of the impacted tooth. First point on that would be the ratio of the root width towards the apex and the crown root junction width. As it is shown in the diagram, when you have a smaller root width than the crown root junction width, then you have more slender root that could be easily delivered out. When you have a wider root width against a crestal width, then you have bony undercuts in your root that may not permit a smooth path of exit. Thus, variations on the root's shape and size must be evaluated properly on your radiographs. Be careful, however, because sometimes on quick look, a radiogram may show a slender appearing root morphology, but in actuality, it has root variances that prevents its smooth path of delivery. The second point of interest with regards to the roots of impacted tooth is its number and morphology. Whether it has a fused root or a multiple root matter in terms of having a smooth path of exit for the roots. Likewise, a slender, more conical root would allow unimpeded displacement compared to a more bulbous or roots with curvatures. This simply means that the more complex the roots are, the more difficult it is to remove it. It is important to note still that standard two-dimensional images may not show all the variances in the roots, and thus careful review of these images is consequential. Three-dimensional images could be of help in these situations.